Selecting VEGF inhibitors is a little bit tricky. They are similar in theory. The list of side effects the patient reads is almost identical, drug to drug to drug, but the side effects they get from a given drug vary, and how well the drug works can vary. I've had patients who have had their cancer grow right through, for instance, pazopanib, and then we add in cabozantinib, and the tumor shrinks and they have much more time on that. I've had the reverse occur, where after a long run of pazopanib, we try cabozantinib and it really doesn't buy them anything additional. I wish we knew biologically what was going on and how to explain that, but I think it's much more picking your first drug, then trying a second, trying another one. They all are a little different. The one that's the easiest for me to get to a tolerable dose for patients is axitinib, mostly because it comes in 1 milligram tablets, so we can really fine-tune the dose patient to patient.
In the frontline good risk setting, sunitinib and pazopanib are pretty interchangeable. Now, there's been an evolution in how we use these agents. Sunitinib officially is given 4 weeks on and 2 weeks off, but very few people are doing that now. We and others have published that if you give sunitinib 2 weeks on and 1 week off, that it's better tolerated, and there's some evidence that people might actually be doing better, although we don't have randomized data to prove that. But the same is true also for pazopanib. Although this drug's supposed to be given daily, continuously, people are now taking breaks when they're taking this agent, and overall the tolerability of these anti-angiogenic agents has improved compared to historic controls. And this is really, I think, because both patients and physicians know how to use them better.
When we choose to start single agent VEGF inhibitors in renal cell, my first choice is pazopanib, based on the COMPARES data, which compared pazopanib to sunitinib, both approved frontline agents, similar overall survival. Pazopanib was much better tolerated. And so we really have leaned on those data since those data came out and used that as our single agent VEGF of choice. There's some data with axitinib in the frontline setting, but it's surprisingly not as robust in cross comparison. And the other advantage to pazopanib over sunitinib is the consistency of dosing allows for consistency of dosing of the patient's other medications, like their blood pressure medications, which would need to go up and down based on whether someone was on drug or not. Sunitinib, in contrast, is dosed in an on-off fashion. There are varying different ways to do that, but as part of the drug, we know it's best used on and then off. And that just becomes more cumbersome to manage other medications.
In thinking about some practical advice to give about how to use VEGF TKIs, I have to say that they're pretty similar in terms of their overall toxicities, although there's some unique features. For example, pazopanib has hepatitis to a higher degree compared to sunitinib or cabozantinib. At least in my experience, cabozantinib has potential for more devastating fatigue than the other two. And this is also true for axitinib, the companion for pembrolizumab and avelumab. I think the guiding principles really here are that we need to make sure that when individuals develop side effects, they should take breaks. And it's important that they let the normal tissue biology recover, and that's probably going to recover faster than the tumor is going to be able to start growing. And by doing this, we're going to end up allowing individuals to have higher area under the curve long term in terms of dosing, and are going to likely benefit from these agents more.